Good. I think we're all here. I'll call the meeting to order, and if you'll rise with me for the Pledge of Allegiance. I pledge allegiance to the flag of the United States
United
of America
States of America
and to the
and to
republic
the republic
for which it stands, one nation,
one nation,
under
under
God,
God,
indivisible,
indivisible, with liberty
and justice for all.
Thank you.
Thank you. Dee, if you could call the roll.
Director Nicholson,
Present.
Director Yee,
Present.
Director Stewart,
Present.
Director Epen, Director Wallace,
Present.
Great. Thank you.
and
well-
Dr. Nicholson, I'd like to let you know who's in the room here.
Thank you.
We have Kimberly Hartz, Ed Fayen, Chris Henry, Tina Nunez, Stephanie Williams, Paul Kozachenko, Shri Badu, and myself, Dee Antonio.
Great. Thank you very much.
Also, this meeting is being recorded.
Yes. So welcome to the February 10th, 2021 regular meeting of the Washington Township Healthcare District Board of Directors. To comply with Alameda County's Order Number 21-01 as issued on January 25th, 2021, to comply with social distancing measures and other restrictions necessary to control the spread of COVID-19, this meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. Governor Newsom's Executive Order N-2920 explicitly waives the Brown Act provision that requires the physical presence of members, the clerk, or of the public as a condition of participation in or quorum for a public meeting. We continue to comply with the Brown Act in providing dial-in information in order to provide the public the opportunity to attend the meeting. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members who would like to speak at this? Are there any members of the public who would like to speak at this meeting? Seeing none, we'll move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve in one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Hearing none, does any member of the public want to remove an agenda item from the consent calendar? Hearing none, may I have a motion to approve the consent calendar items A through D?
I move approval. Oh, sorry.
I second.
Thank you. We have a motion and a second. Dee, can you take the roll?
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Epen, Director Wallace.
Aye.
Okay, the consent calendar passes. Dee, there were no oral communications. Do we have any written communications?
No, we do not.
Thank you. I understand we have an excellent presentation tonight. Kimberly, if you could introduce our speaker.
Yes, thank you, Dr. Nicholson. It's my pleasure to introduce Dr. John G. Kostoros. He joined the Washington Hospital Healthcare System in November of 2019 and he is a shoulder disorders specialist and shoulder surgeon at the Institute for Joint Restoration and Research. Dr. Christoris has devoted his entire career to becoming an expert in the comprehensive treatment of all disorders affecting the shoulder, from sports injuries to fractures, rotator cuff tears, instability problems, and arthritis. As a prior full-time member of the Stanford Orthopedic Surgery faculty, he has trained hundreds of surgeons from around the world and has shared the very latest advancements and techniques. Although many injuries of the shoulder can be treated without surgery, those that will require an operation can be treated today with arthroscopic surgery, a minimally invasive technique that requires minimal downtime and enables faster recovery. Dr. Christoris also specializes in shoulder joint replacement surgery for more complex problems, such as advanced arthritis or some irreparable rotator cuff tears. He's been a leader in developing cutting-edge technology for shoulder surgery and has led multiple FDA clinical trials which have benefited patients throughout the country. He is partnered with Dr. John Dearborn at the Institute for Joint Restoration and Research, where they share the same philosophy of providing patients better and more consistent care in a specialty setting focused on exceptional outcomes, service, and quality. So Dr. Christoris, we're pleased to have you do your presentation this evening to the Board of Directors.
Thank you, Kimberly, and I want to thank the entire board for this very nice opportunity. I'm going to share my screen and hopefully everyone can see my first slide. Is that clear?
John, I think you need to turn on your video.
Yeah.
Okay, let's go back to that and just one moment. Okay, let's go back over here just a moment.
Oh, now we can see you
Okay, good evening. We'll try this one more time.
and we can see your slides.
Okay, perfect. Okay. So again, I want to thank Kimberly for that very nice introduction, and I'd also like to thank the board and Ed for the opportunity to present to you this new shoulder program that is now available at Washington. And on a broader scale, I want to thank the entire staff and community who have worked very hard to help me launch my new practice. So my journey, interestingly, has its roots in Fremont, which is where I spent my early years of life. My father was a professor down at San Jose State. And I began with a high school down in Bellarmine, where water polo and swimming were my athletic sports of choice, kind of introduced me to shoulder injuries at a young age. And much like Dr. Dearborn, we kind of followed a similar pathway with undergraduate work at Stanford, UCSF med school residency, Harvard for fellowship. I did shoulder and sports. And then I went off to Switzerland, where I learned some new techniques that weren't available yet in the US and brought those back to Kaiser as chief of shoulder there, and then eventually over to Stanford. And so here I am today. It's been a real privilege and a really perfect synergy to join Dr. Dearborn at the Center for Joint Replacement to really build out the shoulder program from the ground up. And so it's been really an exceptional opportunity to work with our team in nursing and surgery and pharmacy, radiology, and many others to really build out a lot of clinical pathways and patient education tools, et cetera. So as Kimberly nicely outlined, my whole career has been really focused on the shoulder. This is Dr. Codman, who's credited with performing the first shoulder procedure in the early 1900s. And so rotator cuff tears are a common problem, the most common problem that I'll see in my practice: sports disorders, instability problems, trauma, joint replacement, obviously. And then I have a particular interest in revision surgery. And then we employ both arthroscopic and open techniques to achieve these ends. Now, sometimes surgery isn't the first choice. And so we've seen a huge explosion in biologic therapies like stem cells, platelet-rich plasma. And these are some of the other elements of my practice here that I will undertake. Some are more aggressive than others, like a tendon transfer. Here we see a plate and so forth and so on. And one of the things that's most exciting about Washington is we are the only site in California, actually west of Phoenix, offering a minimally invasive stemless reverse shoulder replacement, which we see here. And so this is a really nice opportunity for patients in our community to be part of this. And it's going very well so far. So I consider the shoulder, as many others, to be the most complicated joint in the body. It has a wide range of motion, it's minimally constrained, and it has a lot of structures that are prone to injury over time. From young patients to older patients, we have the rotator cuff, we have the capsule deep to that, we have ligaments, we have the labrum, and so forth and so on. These things can all be injured by wear and tear over the years with trauma, across the whole spectrum of ages. And so as we approach the clinical evaluation of the shoulder, this is our outline of how we will conduct our assessment of patients. So I'm going to give a brief overview of some of the more common problems that I see in this short time. Rotator cuff tears being number one. They pose a significant impact to society, as we know. They affect 50% of the population aged over the age of 60. They account for a really significant economic cost to our society, decreased productivity, and this will really be a larger problem, I believe, as time goes on and people live longer and longer. It's the most common problem that I'll see in my practice, and it causes significant pain and disability in patients across the spectrum. Now, one of the things that's unique to rotator cuff tears, which maybe many people don't quite appreciate, once the tendon is torn, it doesn't ever heal back. And over time, the muscle and the tendon will go through a process of degeneration and be replaced by fat. We call this fatty infiltration, as we can see here on these MRI images over the span of just 2 years. So this is looking at one of the muscles of the rotator cuff, and you can see the whiteness increasing over time. And that is what fatty infiltration looks like. It's correlated with function, degree of pain, and whether or not this can be repaired with surgery, and eventually tears become non-repairable. This is looking under the microscope of what a normal muscle looks like versus a fatty infiltrated muscle to your right. Now, in the old days, rotator cuff repair had a reputation for being a very painful undertaking. These were large incisions, we would split through muscle, and patients would take time to recover, and oftentimes would be in the hospital for several days. Over the past 20, 25 years, we now have arthroscopic techniques. It's elegant surgery, it's less invasive, and this has really become the standard for the majority of tendon tears, as we see here, performed through very small incisions. This is a video of one of my cases looking at a torn rotator cuff tendon there. And so we have nice devices called anchors and sutures and various techniques to repair back to normal anatomy a rotator cuff tendon tear, as we see here. And many of these operations should not take more than about 30 minutes at a time. Outcomes are excellent. These are outpatient procedures. Physical therapy is critical, but it still takes a good 4 to 6 months for patients to recover. Now, rotator cuff tears are not always repairable, and if they aren't, we do have some salvage options available. I was invited as a visiting professor to Japan in the around 2011, and at that time, I learned and observed a new technique where a cadaver graft is used to kind of buttress and substitute for parts of the rotator cuff tendon, which is not repairable. This has since become available over here, and I was one of the first to introduce this technique here in the United States. And so this shows a picture of that graft being shuttled into the shoulder from the outside and then repaired to the tendon. And we see here a patient who underwent this procedure who was pleased with his outcome and did relatively well. Now, beyond rotator cuff tears, what about instability problems? The shoulder is an inherently unstable joint. It has a wide range of motion, and in some cases, excessive motion can become pathologic. People can feel a sense of instability, or in more severe cases, such as with trauma, the shoulder joint can dislocate, as we see here, causing damage. And so this is an arthroscopic kind of video of a patient who has a tear of the labrum, which is important for stability of the shoulder. And we have nice minimally invasive devices such as this to repair the labrum, retension ligaments, and restore anatomy back to normal, as we see here. Beyond instability problems, we see patients who suffer from fractures of all ages. This is a professional rugby player, very severe fracture here. And although some of these can be treated without surgery, depending on the alignment, some perform better with plate and screw fixation, as we see here. And this is a post-operative x-ray of what it would look like. We also have other bones around the shoulder girdle, like the collarbone or the clavicle, which can become fractured. Here's a cyclist, weekend warrior type. We see a lot of these here in the Bay Area. And so depending on alignment and fracture configuration, some can be treated without surgery. But in this case here, surgical treatment is recommended. And then finally, arthritis, which is something that we all suffer from over time of varying degrees. It's the loss of cartilage in the shoulder, and it's characterized by pain, loss of motion, pain at night, and various ways that affects our quality of life across the entire spectrum. There are various forms of arthritis, with primary being the most common, but we have inflammatory arthritis like rheumatoid arthritis. These are all various forms of arthritis which can be treated. We begin with non-operative methods first, like anti-inflammatories. Some of the biologics are gaining some interest, although the evidence is still TBD, to be determined, but certainly of interest. We have arthroscopic methods for less severe cases, and then we have joint replacement, which are very predictable methods today with respect to eliminating pain and improving function. For younger patients who are more active and may not be interested in joint replacement, we can offer arthroscopic techniques, but the outcomes are a little less predictable, less durable, as the arthritis is not reversed. Joint replacement is really the mainstay of advanced arthritis, and it's the fastest growing segment of the joint replacement market worldwide over the past 15 years. And so we have a variety of different devices which are available to offer to patients. This was a patient of mine that was featured on the front page of the San Francisco Chronicle in 2010. And so he's had bilateral shoulder joint replacements. He's doing very, very well. And this was just a feature to highlight shoulder replacement. Stemless replacement, which is less invasive, is a particular area of expertise and interest of mine. I've been part of three trials of various devices. I've helped to develop some of these. They're bone preserving, they're less invasive, patients recover more quickly, and it's really an outpatient procedure today, which is remarkable compared to even 10 years ago. And so here in Washington, we're offering the first US FDA clinical trial of a stemless reverse shoulder replacement, which is depicted here. And so it's really doing very, very well so far. This is a patient who had an anatomic stemless replacement. We see advanced arthritis of the shoulder. And to your right, you can appreciate what a stemless device looks like. And here are some images of what this particular patient's function looked like after surgery, which is near normal, if not normal. Now, the reverse replacement is something which was FDA approved in 2004. This is what I brought back from Switzerland, and it's a unique, really engineering feat in my world, where this is for patients who have rotator cuff insufficiency, and so it changes the mechanics of the shoulder to give a mechanical advantage to the deltoid muscle to elevate the arm. And so this is what this device looks like here, and it's really a wonderful device for patients who previously didn't have many options on the table for them. It's sometimes used for patients with complex fractures, especially older patients where the plate and screw construct wouldn't work very well. And so here we see an example of a fracture-specific reverse prosthesis. So what does the future hold for us? Well, precision medicine is really where we are moving more and more towards. We have augmented reality and virtual reality and enhanced surgical planning tools with software that enables us to virtually perform surgery before we even get to the operating room. Here's a previous fellow of mine performing a shoulder operation with these augmented reality goggles before he even gets to the operating room. So moving forward, I think some of these techniques are going to evolve more and more. It's very exciting. We have advances in tissue engineering, which are in development, and evolving growth factors and stem cells. So in summary, I consider the shoulder the most complex joint. A variety of problems are possible across all ages. Most problems today can be treated arthroscopically, which is minimally invasive if surgery is required, and we have various exciting new techniques on the horizon. So thank you, and I'm happy to take any questions.
Thank you, Dr. Kostouros. That's a very interesting presentation, and shoulder problems are extraordinarily common and debilitating. We're really excited to have you and your capabilities and this expertise here at Washington to be able to offer those to our folks in our community. Are any member of the board have any questions? Well, I guess they're not having shoulder pain tonight.
I just
Oh, there
want
he
to
is.
say, Doctor, my shoulder problems have always been cured with TheraBand and exercise. So do you have any kind of observations about how those kind of exercise procedures can eliminate any kind of surgeries?
I apologize, my internet went down briefly, so if you could repeat the question, I'd appreciate it.
Well, I went through a year of process where I was getting shots in my AC joint, and I had my neck stretched. I went through all kinds of procedures until a physician up in Oakland said, well, you have a minor tear on your rotator cuff, and you can fix this with a exercise with the TheraBand. Stretching your arm in the shower or wherever, and you won't ever need any surgery. So, and actually, I was kind of amazed because a year earlier, John Heine, who is a retired physician on our staff, told me that I should do that, but I didn't listen to him. And I went down this whole pathway to try to figure out how I should fix my shoulder because I was having a tough time putting my arm over my head. And in retrospect, Heine was right. I should have just went and did the TheraBand, which then fixed my problem and with the exercise. So I mean, I'm asking you, I guess I'm asking you, how much do you think that folks could be cured by that kind of exercise versus any kind of surgery?
Well, to your point, I would say that the vast majority of shoulder conditions do not require surgery. So that's where I'm going to preface things. And I treat many, many patients in my practice without surgery. The presentation was more focused on the surgical side, certainly. Some patients actually with partial tears or even some full thickness tears can rehab their shoulder with physical therapy, strengthening, stretching exercises, some injections, and get to a pain-free state, which works for them. Now, for some of the larger tears, if you objectively measure strength side to side to a normal side, they are going to have some weakness because structurally the shoulder is not connected the way it normally is. But if it doesn't cause symptoms and patients can take care of themselves and participate in sport or exercise to their liking, then surgery can be deferred. And that holds true for rotator cuff problems and some instability problems and even arthritis. So I think we just go through a stepwise approach to care, beginning with the less invasive methods first. And if it gets to a place that's not acceptable, then we can become more aggressive with some surgical methods.
Okay, well, thank you, doctor. Thank you.
Thank you.
Mike, I hope your shoulders are holding up well now.
No, I mean, it's perfect. Actually, the doctor told me that, well, it's gonna be like a couple of weeks when you do these exercises, and actually it was like 10 days, and I was like new, so it was amazing to me after a year of struggling through this whole thing, and planning a surgery on my AC joint to get rid of arthritis, which is in my AC joint, but that wasn't really the cause of the problem. So,
Yeah, I think this just speaks to Dr. Kostoros's point that shoulder problems are extraordinarily common and often quite debilitating. So we're really glad to
Yeah.
have you here, Dr. Kostoros. And
Yep.
we appreciate your expertise. And I suspect if Mike's shoulder acts up again, he's gonna be giving you a visit.
yeah. Oh, I'm gonna look you up. Yeah.
It would be my pleasure.
Yeah.
Okay, thanks again.
Thank you.
We'll now move on to our medical staff report. Dr. Killaroo.
Thank you. So I'm happy to say we have a grand total of 588 physicians on the medical staff, including the allied health personnel, 355 which are active. I'm also proud to say that over 90% of the physicians have received their vaccine, and we've had multiple educational endeavors with our physicians, and all of them have been very proactive about getting the community to get on board with the vaccination program. And again, I want to commend Washington Hospital. I've had patients in other areas. In fact, a patient recently from Redwood City complimenting how well our vaccine rollout has been going compared to what's going on in their county. We also had a recent grand rounds on interventional radiology. Dr. Bruce Lynn and his new partner gave us a very thorough update as to what is available here. We had a dry run with the crisis standard of care. If you remember, that was approved by the board. And we didn't actually go through the whole part, but we had the ICU staff do the scoring and do the color coding. And we're gonna set up a meeting with the potential triage team to at least do a dry run. Hopefully our numbers are going down, so we won't need to do that, but I figured it's better to at least have it done and not need it than the other way around. And then finally, it's that time of the year again. My tenure is going to be completing in June of this year. So we've kind of set a call out for elections, not only for the chief of staff elect position, but there are several department chairs that are going to be turning over for, and so those elections will be happening in the next few months as well. And I'll keep you updated as far as the results related to that. And that's my report. Thank you.
Thank you very much, Dr. Killaroo. Any questions from the board members? Okay, if not, we'll go on to our service league report. Ruth, I understand this is going to be your
This is
final
it.
report.
My final report. Hello, everyone. It's good to be back and to see you. We have been on somewhat of a hiatus as the volunteers, but we're slowly coming back in limited numbers to do some special projects here at the hospital. So we went on hiatus in March of 2020. So it's been an interesting year. We came back in the fall with the opening of the gift shop. We met and worked with administration, and we worked with the infection control department to ensure that we had all the protocols in place, that we were following the guidelines, and we did that successfully. So we're very fortunate that we have an organization that was looking out for the volunteers as well. We've been working recently with the laboratory, working to assemble COVID testing kits for them to help them move along as they are busy. So that was something that in limited numbers, those that have been approved have been able to come in and assemble those kits for the laboratory department. So, and also we pivoted, as we would say, with the volunteers, and we did monthly Zoom meetings, and Kimberly Hartz came on and kept the volunteers updated as to what was happening in the organization. And the volunteers were extremely happy and very receptive of that. And so thinking that they're volunteers and maybe a little older, we had a very good participation with the volunteers participating in our Zoom calls. So we really would like to thank Kimberly for keeping the volunteers connected and feeling like that they were still important to the organization and that they're looking forward to the day that they can come back. Last but not least, as you did say, this is my last meeting and my term is ending. So it's been a very much an honor to be here representing the Service League. And I will be turning over the reins to Debbie Fieri, And she's sitting in tonight to get a glimpse of what occurs with the board meeting. So I'd like to thank everyone for supporting the Service League, and we will be back to support you in full at the appropriate time. Thank you.
Thank you so much, Ruth. Kimberly, I understand you have some comments.
Well, I just want to really thank Ruth for all that you've done. I mean, in terms of this time, it's been your steady leadership and willingness to always jump in when needed that has really made a difference for the volunteers during this challenging time.
Thank you.
I mean, it's really in terms of being able to offer the information that they were looking for, and to really work in partnership with us as we try to look at ways that we can bring back the volunteers. So personally, it's been a pleasure working with you this last period of time, and of course I look forward to working with Debbie. But I know that I do want to say, I know you started the WOOF program here, K9
Yes.
program, and everybody's looking forward to hopefully in the
Bringing
near
it-
future being able to get that up and running again.
Yes.
And really thank you for that, and so much more in terms of the work that you've done to help support the hospital, and whether it's the SDN and the beds and all of that that the Service League helped to provide funds for. So we wish you the best. I know we'll
Thank
always
you.
continue to see you, and that you are joining the charitable foundation. So
Yes, I am.
we'll be able to see you there too. So thank you very
Okay.
much, Ruth.
Thank you.
Thank you, Kimberly. I can only echo Kimberly's comments, but I'd like to call on somebody who might have some more experience and perspective on the Service League, and that would be Director Jeannie Yee. Jeannie, can you make some comments?
Oh, my pleasure. As someone who has had first-hand experience working alongside Ruth, I can just only say I so appreciate her leadership. It's doubly impressing that a 38-year employee of Washington Hospital would want to come back to serve the hospital, and humbly be trained by volunteers who didn't know she knew the hospital inside and out. And so getting to know Ruth has been a privilege. And I take my hat off to her, because she is breaking the tape running as she finishes her term. She lightly mentioned how we've taken on helping the laboratory, but that came about primarily because she used to work in the lab, and she ran into friends and found out how they were struggling because of making these kits it was taking so much time. And in her mind, she's thinking, that's something we can do. The volunteers have been wanting to do something to help. We've been on the sidelines just chomping at the bit. Use us. Where can we serve? How can we help? And this was the perfect opportunity for her to coordinate, and she just has stepped in and coordinated that whole effort, arranging with the lab when we need supplies. And she knows these people. She calls them all up. They know her, and it's just a great setup. And what a way for us to be able to serve the lab in a way that volunteers never get to do that. Our services are in other areas. We never get to support the lab. So it's been a great opportunity, and Ruth has just made that happen and made it successful. And it's very satisfying to make those kits, to see those bags fill up, and to know that we're saving them valuable time. They don't have to do this. They can rest and know the kits will be ready. They can be handed out to the ER, to different clinics, whatever, it's done. And so it's just been a privilege to see Ruth shine at the end of this term, and to know that she is truly breaking that tape running. So I just thank you, Ruth. Look forward to continuing
you.
working with you. I love you, and
Thank you.
glad that we're on the same team.
Thank you. Thank you, Jeannie. Yeah, Ruth, you've set the bar very high. And Debbie, you've got some big shoes that you're going to have to fill. So we have high expectations, and we know who you can call on should you need some guidance or advice. And so, Ruth, I wish you the best in all your future endeavors, and especially on the Charitable Foundation. Thank you
Thank
so
you
much
very
for
much.
your work.
Thank you.
Okay, we'll move on to our lean report. And Kimberly, if you could introduce our speaker.
Yes, it's my pleasure this evening to introduce Charlie Sachs. He's our Director of Materials Management. And Charlie was born at Washington Hospital, is a manufacturing and supply chain leader focused on driving lean transformation for operations. Charlie has worked for 20 years in several roles from manufacturing to healthcare, continuously developing, applying, and transferring his lean knowledge through a hands-on approach. After 13 years with Toyota, Charlie applied his experience in other industries, including solar, fuel cell, and healthcare, along with consulting from high-tech to food and dairy. Charlie has a passion for fishing, and in 2018, purchased a sport fishing charter business in Hawaii, taking a business that was run by pen and paper to now fully automated, improving profitability through lowering expenses and increasing revenue. And Charlie just recently joined Washington Hospital in May of 2020. So welcome, Charlie, and we look forward to hearing your presentation on supply chain.
Charlie, you're muted and your video is off.
Okay, you guys can hear me?
We can hear you. Can't see you though yet.
Okay, working on that. Can you see me now?
We can see you now.
All right. Good evening. My name is Charlie Sachs, Director of Supply Chain. And as Kimberly said, I started in May of 2020, so going on 9 months now. And I want to share with you what we're doing in the supply chain within the framework of a lean management system. Within the supply chain, I'm going to actually share screens. That's ready? Okay. Thank you. Next slide, please. So within the supply chain, we have purchasing, the general storeroom, and sterile processing. The core functions within purchasing, value analysis. This is the process we use to approve new products to be used in the hospital. Once those are approved, then we need contracts in place with the right terms, the right price. And we have the buying function to process requisitions for everything that people are ordering and getting those orders out to the suppliers and making sure those products are arriving when they need to arrive. And then the ERP management, which is just the upkeep of the data in the system that's needed to run the operation. Some challenges in purchasing around contract and PO management and invoice processing. I'm going to highlight PO management, for example. Less than 50% of our POs go out by EDI, so that means that more than half of them are being handled by phone, email, or fax. And our buyers are spending, up to 2 hours per day following up and managing the confirmation of the purchase orders. Going over to the storeroom, the core functions there are receiving at the dock, so everything that comes in. Inventory, we manage 1,300 different items in the storeroom. And distribution, we're servicing more than 50 locations around the hospital to stock supplies, in addition to having WTMF for the locations outside the main hospital that we're servicing as well. And some of the challenges there are the call volume, inventory accuracy, which I'll get into more detail later in the presentation, and stock outs. And one here to look at, for example, call volume. We're averaging about 80 calls per day, and these calls are from our clinicians in the different units that are requesting products that they don't have in their unit. Either it's not stocked there, or it's stocked and it's not available. And then looking at sterile processing, the core functions there are processing the instruments, cleaning and sterilizing, picking supplies for the OR cases, collecting soiled equipment and cleaning and redistributing the clean equipment. This is patient equipment, such as the Laris pumps, for example. Crash carts restocking, and then managing the inventory in the cath lab. And some of the challenges there: instrument errors, returns, equipment availability. Instrument errors are when we don't have the right item in the tray, or it's missing or wrong. Returns, we've been seeing somewhere around 20% of the items that we're picking for case carts and sending up are coming back. And equipment availability, especially recently in December and January, we've had higher census, higher COVID census, so more acuity, more equipment being used per patient. And so we've had to, even rent some equipment temporarily to try to fill those gaps. But it's quite a strain on the team trying to, make sure that the equipment is available where everybody needs it when they need it. So kind of understanding the functions, the work that we're doing, and some of the challenges that we have. Then it's, next slide, please, looking at the framework of the lean management system and how we want to use this to improve the performance of our operation. So it starts with strategic deployment, where the vision and the goals for the organization are cascading down to all the way to the front line. And so when I got here, I saw we had boards up in the frontline areas, and the leaders of those areas were huddling with their teams and going over certain things to determine, are we ready for the day, things that may have happened yesterday that we need to talk about, and is there anything that we can do to make sure that those things are resolved. So that kind of moves right into the active daily management there. And that's when we get into, okay, well, we're measuring things, but now what? And so then it gets into the problem solving, looking at our standard work, and then continuous improvement. And then through that activity, then it's changing our behaviors and the way we're thinking and our habits, and that gets into the leader standard work and the development of ourselves and of our people, our employees. And then that circle repeats. Next slide, please. And this is just another way of kind of displaying the active daily management structure. So at the bottom there, you see, I'll call that tier 1. That's where the 3 areas are meeting at their frontline boards, and they're huddling about kind of how are ready for the day and issues that they're having. And then I started this huddle in my office. We met in July, and we identified the things that measure the performance of our operation and the health of our operation. And so we developed the things to measure, and then we established targets to start with for the fiscal year. And then at the end of July, we started this huddle in my office. And next slide, please. So here from what I understand, you guys have seen these boards before. The top ones are the frontline boards, the bottom ones, the process owner boards. And so the top, they're meeting with their staff on a daily basis, like we talked about. And then the process owner boards, weekly, we do a Gemba where the lean group, along with Nick and Ed, come down and we work with the leaders of the areas to go through kind of the bigger picture of how they're doing towards the goals and the work, the work and the progress that they're making. Next slide. And this is an image of what's on my wall in my office. Actually, if anybody's ever been in that office, there was quite a bit of furniture in there, and I'm big on reducing clutter, and so cleared out the room with some extra furniture that was in there, and then put this magnetic dry erase wall board on the wall here. And on the left, you'll see the leader standard work. So those are the things that I wanted to focus on in terms of kind of creating those habits for myself and keeping my eye on the ball on certain periodic things that I need to do as well, weekly and monthly. And then the metrics that I talked about are in the middle. And so when we're huddling together, my direct reports, from each of the areas. They're reporting the status and providing the numbers, and we're updating those, and then we're assigning those a red or a green. Green, we're meeting the target. Red, we're not. And then if we're not, okay, what's going on, and what do we need to do? Some of these things we can work on quickly and resolve easily. Some are bigger projects that take more time. And then the hot list, that's just where we're keeping an eye on certain hot topics that have been important for us to keep our eye on and make sure we're talking about. PPE has been a big one. We've spent a lot of time working on PPE, and through our normal channels, we're not able to get a lot of things. So we've had to go outside of that and kind of search on our own and try to find quality products that we can bring in at a reasonable price. And it's been tough, but the team's made a lot of progress, and I think for Washington Hospital, we're positioned pretty well with having the right protective equipment for everyone in the hospital. Next slide, please. And so then from that, I'm collecting that information, and I'm capturing it, and I'm training it over time. So here's where you can see the progress that we've made. Some are still red, some are green, and so I wanted to highlight some of the success stories for the green ones. Next slide, please. So in the storeroom, as I mentioned earlier, inventory accuracy. So, about a month in, we had to do the year-end inventory at the end of June 2020, and the result of that was 41% inventory accuracy. So out of 1,300 items, that meant almost 800 of them had some variance, meaning the physical quantity didn't match what was in the system. And so what we did essentially was start a new cycle count program where we started cycle counting the items in the storeroom, a certain amount of those items every day, and trying to, by doing that, learning and understanding what might be causing those different variances. So focusing on standard work, auditing some of these. So when the staff are going through the storeroom, they're picking the items that they need to go deliver to the units. We would randomly stop and audit and check the contents to see that they match what was supposed to be picked, to see if we find anything there. Daily transaction discipline as well. So what we were seeing was staff were picking the items and delivering the items, but not following the standard work for the transactions. And so some of that was getting pushed to the side, and then it was kind of come back to it later, and we'll get to it when we can. And so some of this was accumulating, and that can cause errors in transactions being entered that could cause part of the problem as well. And so what you can see on the chart there is you can see the progress we've made. That first July bar, there was only 2 days, and one of them was 70%, which was actually rare at that time as we were getting started. But you can see how we've evolved through the 1,300 items. It takes us about 6 weeks to 2 months to get through all of those, and then we start over again, essentially. And so you can kind of see August and September, and then we raised the bar for October and November, the next time we went through the items, and then December, January, the last time that we went through that cycle of those items. So we're seeing some improvement there. Still some work to do, so we set the target for 75%, and that was based on where we were at the beginning when we were starting with a 41% inventory. We said, let's start with 75. We can get to 75, then we'll raise the bar again. In purchasing, the issue of PO lines, purchase order lines are overdue, essentially meaning that we've ordered something and that order is still outstanding and the product has not arrived or has not been received. And so what we did there was first we drew a line and we said, all right, anything greater than 48 hours open, because, within 24 to 48 hours, you may have a little bit of a delay in shipment or a little bit of delay of something getting received. And so we drew the line at 48 hours and said anything greater than 48 hours. And so we were at somewhere around 600 to start when we started tracking the number. And a lot of that was just old data that was in there that needed to be cleaned up, that wasn't relevant. But how do we know if, we're healthy in terms of everything we're ordering is coming in when it needs to come in, and we're receiving it and we're getting it where it needs to go. So we had to clean up a lot of that old data and clean up that noise in the system first. Then we started a daily review. The purchasing team works with our distributor as well for a huddle every morning for 15 minutes, just to look at, hey, what are the orders that we have outstanding, and what's going on, what's the reason why we didn't get it, and they work through that. And so that's helped as well, along with collaboration with the storeroom team. The other reason things are on this list is we've received it physically, where we have proof of delivery from, say, FedEx, for example. So we know it arrived, but it hasn't been received. So why hasn't it been received? So then we get the storeroom involved and talk to the receiving team member and try to understand, hey, did this come in? And you signed for it. How come it hasn't been received yet? And so we've seen more collaboration between purchasing and the storeroom trying to resolve these things. And then finally, another example is in purchasing as well. Not all purchases tied to a contract, and so that may mean we're paying a higher price than we should. And so, literally talking to the purchasing manager, his name is Vince. You guys may know Vince. I believe he just got his 30-year employee recognition, or he's getting that now. And so Vince had to really go one by one and rebuild those contracts in the system and make sure everything was right, the prices were loaded right. And then we started checking the spend daily, so the amount of money that we're spending on supplies every day, what percentage is on contract. And so we drew 80% again as our starting point. And you can see where we're at on that. So we're in the mid-80 range now, which is pretty good, actually. But, in the spirit of continuous improvement, with all of this, as we improve, we'll raise the bar, and we'll keep pushing for more. And so that's the approach. And next slide, please. So the next steps is to continue this process and continue evolving with this, and trying to focus on driving those improvements on the core aspects of our business. And then I'm also working on a supply chain strategic plan that I've started reviewing with Nick, and so working on getting that up the chain, so that I can share with everybody, what my idea is for supply chain for the future at Washington Hospital. And I just wanted to take a moment to just, again, recognize Vince in purchasing, and Victoria, who's the supervisor in the storeroom, and Krishan, who's over the sterile processing. Those three have been great, and especially with the pandemic, the extra work that was added to them for managing, trying to find PPE and make sure the PPE is available, and all of the work that comes with that behind the scenes. And then even Krishan in sterile processing, we've taken on additional work, such as we have the different masks, we call them P100 masks, like respirator masks, along with some newer technology, power systems that kind of achieve the same goal. And so he's taken on collecting those and cleaning those and making those available as well. So each of these leaders, they've all taken on more work on top of the job they're already doing. And then with Vince, one last thing to leave with. This fiscal year, we've achieved approximately almost $250,000 in savings, and a lot of that's just through better contracts, better pricing, and even some conversions, some basic easy conversions from one product to another that has the same value, but we can get it at a better price. And we have about another 250,000 in the pipeline that we're working on. And so we expect in this fiscal year we're going to get close to about $500,000 in savings. And this is kind of let's call it like the low-hanging fruit. There's a lot more that we see that we want to go after, and so we'll be working on that and building that into the plan for the future. And I'd say that concludes my presentation. If there's any questions.
Well, thank you, Charlie. We're very impressed with the work that you've done, and I know the clinicians in the house are very appreciative of the great work which has been done on behalf of your team to get the PPE which is necessary for us to take care of patients. So very glad to have you on board. I'm sure you're going to be fishing for more opportunities, and we hope that you'll continue to reel in the opportunities and operational efficiencies and savings. So thank you so much. Any questions from the other members of the board? Well, if not, thank you again, Charlie. And we'll now move on to our quality report on the Washington Hospital dialysis program from Dr. Jeannie Yee. Excuse me, Jeannie Han. Now you got me confused.
Yeah, well, I will take a minute to introduce Dr. Jeannie On. As many of you might know, she is the medical director of the acute dialysis services at Washington. And Dr. On has been a community nephrologist in Fremont since 2001. As I said, she's medical director of Washington Hospital's acute dialysis service and also medical director of DaVita in Fremont. She went to college at UC Berkeley and graduated from the University of Illinois at Chicago School of Medicine. She completed a residency at Kaiser Permanente in Oakland and her fellowship at UC Davis in Sacramento. She is married with a daughter and 2 rabbits. So, all right, thank you, Dr. On, for joining us this evening and talking about the dialysis program at Washington.
Thank you, everybody, for giving me the opportunity tonight to give you some updates on our dialysis program here at Washington Hospital. So we should have a slide presentation. Okay, that's the date. So an overview of our acute dialysis unit. We have offered dialysis here for many years, a long time. Some of the recent history has been that we internalized our service. Prior to 2018, we had outsourced our dialysis service to a company called DaVita Acute Dialysis. And the decision was made by our CEO at that time, Nancy Farber, that we could do better, that they were lacking in some of the services that we wanted to provide to our patients. So in 2018, Washington Hospital internalized the dialysis service, meaning that the dialysis treatments and dialysis nurses were now part of the Washington Hospital staff and not from a external company. The services that our dialysis unit provides includes hemodialysis, peritoneal dialysis, and plasmapheresis. We are licensed for a 4-bed unit currently located on 3 South. This area has recently completed remodeling, including getting rid of our cathode ray TVs, our huge giant TVs. We have LCD TVs now, new plumbing, new wall fixtures, paint, new doors. It is completely new and now allows space for family to accompany the patients during their treatments, which currently isn't happening, but once the hospital's open, they'll be allowed to do that. In addition to our unit on 3 South, the treatments are done bedside for ICU and now also for any COVID positive patients. They are done bedside in their rooms, one-on-one. Our hours of operation were expanded in 2019 when we added a night shift service, so that now there's a dialysis nurse available 24 hours a day, 6 days a week, except for Sundays. On Sundays, on-call services are available, but typically we don't do routine treatments on Sundays. Next slide. So here's a picture of myself, Tigges, our nursing manager, Kirk Kaufman, and some of our dialysis nurses. And we are in our new dialysis space. So one question is, what is dialysis? What is it that we do there? There are two types of dialysis, hemodialysis and peritoneal dialysis. Both of those achieve the same thing. Dialysis in general is a process by which waste products such as toxins, salt, extra water are removed from your body. And the dialysis helps maintain normal levels of certain chemicals in your body, such as sodium, potassium, and bicarbonate. This is basically the work that your kidneys do. So dialysis is like an artificial kidney. So who needs dialysis? What populations require these treatments? So patients with acute kidney failure from overwhelming infection, trauma, drug overdoses, or other sudden catastrophic health events who have kidney failure are placed on dialysis until their own kidneys can recover. A second population are patients who no longer have kidney function due to progressive irreversible loss of function from chronic diseases such as diabetes and high blood pressure. These are patients that require dialysis on an ongoing basis 3 times a week. And when they come for the hospital for other conditions, we continue to provide them with the life-saving therapy. Dialysis is also sometimes used for acute poisonings. It can be used in certain conditions in which we want to remove certain medications or poisons from the body. Next slide. So hemodialysis is when blood is passed through a filter to remove waste products and extra fluid. So the blood leaves your body through a catheter, which is a tube generally inserted into a large vein or from an artificially created vein in your arm, goes through a filter in the machine, and then is returned to you. This happens to be our most common form of dialysis, and the type of dialysis that's used when patients are acutely ill. Next slide. Peritoneal dialysis accomplishes the same thing, but in this case, rather than using blood, the toxins are removed from the body through a catheter in the abdominal space. So clean fluid or dialysis solution is placed into the abdomen. Your peritoneal cavity acts as the filter rather than having an actual artificial filter. After the toxins diffuse into the fluid in your belly, that fluid is removed, and in that way, your body is cleaned and the toxins are removed from your body. Next slide. So plasmapheresis is another service that our dialysis unit provides. It's not a type of dialysis, it's a different type of procedure altogether in which the blood plasma is separated from your blood. Your blood goes into basically a centrifuge that removes the liquid and the solid components of your blood. And the solid components are transfused back into your body, whereas the liquid or the plasma is removed. So this process is used to treat conditions in which there's a protein in the plasma, such as an immunoglobulin, which is toxic to the body. There are multiple conditions, such as Guillain-Barré, such as some vasculitis or medical conditions that require plasmapheresis. in order to recover from those conditions. And we're happy to be able to provide this treatment at the hospital. St. Rose, for example, doesn't have any plasmapheresis capability, but this way our patients are able to be treated here rather than sent to Stanford or other facilities. Next slide. So here's some pictures of our new dialysis treatment area. I think it would have been nice to show you some before pictures, because you know our before pictures of this room look like classic 1970s sort of prison kind of decor. But this is beautiful. We have new floors, new walls. We have a lot of light and air, and it's such a pleasant place to work now. Next slide. So some of the services that we're able to improve upon since internalizing our service include our activities of daily living. Service did not provide assistance with eating. They didn't provide, I mean, I guess they would provide the bedpan, but they really didn't care for our patients the way our nurses currently do. We have more of an emphasis on using the recliner chairs in order to improve mobility, whereas previously it's easier to dialyze patients in hospital beds, and so the patients were in beds all the time. We've coordinated with dietary in order to provide early meals for the patients that run first shift and early lunch for the patients in order not to interfere with their meal times due to their dialysis treatments. Another big improvement is that our nurses are trained bedside nurses, and they administer routine medications. So previously, any medications, pain medications, antiemetics that needed to be administered were administered by the floor nurse. So there would be a delay between the time the patient would express discomfort and the time it would take the nurse to come from their home floor down to the unit in order to give the patient medication. But now it can be done at the bedside, and it's like they have their nurse with them all the time, and there's greater continuity of care, particularly on the patient's side. Next slide. Oh, also, they weren't allowed to eat, but now they are. So service utilization, here's a slide that shows our procedure counts. So our procedure counts typically run 230. Sometimes we have a spike, as in July, when we're particularly busy. You can see the majority of our treatments are hemodialysis treatments. We have a rare treatment, and sometimes we have peritoneal dialysis, but most of our procedures fall into the hemodialysis category. Next slide. Okay, so some of our safety measures include timeout documentation, includes identification of their hepatitis B status. This is important because since hemodialysis involves blood, we want to screen carefully for any blood-borne pathogen. Infection prevention includes making sure that the water we use in our dialysate doesn't have any impurities in it, making sure our hand hygiene numbers are good, and taking COVID precautions. Next slide. Okay, so this is a graph of our time out. The variation looks big, but actually you'll see that we are in the 95 and above for our timeout documentation. We recently had updated timeout documentation parameters for our patients that also includes making sure that the dialysis machine and the access is correct and the hepatitis B is documented. Next slide. Can everybody hear me?
Yeah.
Okay. So hepatitis B
Dr.
study,
On, one
Yeah.
second.
Yeah, I hear
we're
you fine. I hear you fine.
okay.
Dr. Hahn, we're getting noises from your laptop. If you can put it on the solid surface, the laptop you're holding.
How's that? Is this
Yeah, that
quieter?
sounds good.
Okay.
Thank you.
All right, so hepatitis B antigen. So we want to establish the hepatitis B antigen to prevent any bloodborne illnesses. And our prior goal was 20%. You can see over the past year, we've made a lot of improvements. We're now down to the 5 or 6% range, which is excellent. And we'll continue to try to improve on that. Next slide. Okay, this is another improvement that I'm happy to share with you. Our dialysis patient has been selected as a special population for MRSA surveillance. So there was a California law that was passed that requires hospitals to monitor MRSA infection on admission and upon discharge in order to determine whether there's, or how much transmission is going on during hospitalization. So we had struggled with this previously, but over the past 6 months, our compliance with achieving our MRSA screening before and after has been at 100% for the last 2 months. Next slide. Okay, hand hygiene. Hand hygiene goes up and down a little bit. We're a small unit, so you can see on some of the months, there were not enough observations in order for us to reach 100%. Our goal, of course, is always going up to be 100%. We now have a secret observer to help us collect more accurate data. Next slide. Okay, COVID prevention in our dialysis unit. So we ensure adherence to respiratory hygiene, cough etiquette, and hand hygiene, as in everywhere in the hospital. Maintain a consistent supply of PPE. Universal eye and mask protection is worn at all times. We have increased frequency of surface decontamination and environmental cleaning throughout the department and also at the bedside. This is especially important for our dialysis nurses because unlike bedside nurses that go in and go out of the COVID positive rooms, our nurses spend 3 to 4 hours at a time at the bedside. So it's important that they have adequate PPE and that they feel confident in their safety. And since the dialysis is now occurring at bedside, it requires that we do cleaning of surface and the environment of any of the rooms we go into as well. Next slide. Dialysis safety process and audit. So some of the measures in order to keep our equipment up to date include dialysis machine documentation, which is accessible on the machine at all times. Water treatment system documentation is also accessible. We do monthly water and dialysate culture testing. We have a dialysis tech that inspects our machine and our reverse osmosis machines to be sure that they're clean and free of leaks. Our water treatment system is disinfected and documented monthly. And our water safety records are completed and available. We recently had a mock JCO survey and they were very impressed with our record keeping. Next slide. Here's an example of a water culture report. This is done monthly. It records potential colonies for culture. And in order to make sure that the water that we use for our dialysis patients are safe, the water quality is measured so that it meets the criteria for the AAMI. It stands for Association for Advancement of Medical Instrumentation. It is the water purity standards in the community and for the hospital. So Washington hospitals continue to meet and exceed the AAMI standards since our dialysis service was started in 2018. Next slide. Okay, patient education is a service that our nurses provide. Education includes information on diet, care of their access, and importance of taking medications. So we've been working on reaching 100%. When patients come to the dialysis unit, this is often a good time to have these conversations with them because they're our guests for 3 hours or so. Next slide. So our dialysis staff are also educated. Generally, 100% of our staff were trained on all 3 modalities. There's an annual dialysis specific skills validation. In terms of COVID-19, we also want to be sure that they are fit tested, that their PPE equipment is being properly used, so that because of the high number of one-to-one dialysis treatments that have been required due to our high number of COVID admissions in the hospital, we want to minimize their risk exposure as much as possible. For physician in-service, I provided an in-service to the dialysis staff on emergencies, potential dialysis emergencies. And that's an ongoing program. Next slide. Okay, so some of our accomplishments. We've had renovations to the dialysis treatment area to dramatically improve the physical environment. We have achieved the 100% goal for our MRSA screening for our dialysis patient population. We've had reduction of stat treatments. That information wasn't shared but was shared with the Quality Steering Committee. We have ongoing staff perception of feeling prepared, safe, and well cared for during the COVID pandemic. We have improved the timeout process. A EPIC Snapboard was implemented to avoid procedure conflict. So the EPIC Snapboard allows other hospital staff, such as nursing and other providers, to see when the patient will be going for dialysis so that they can minimize conflict with other procedures. We have new policies for improved process during high census. There was a period of time in which our staff was getting very burnt out because of the high number of daily treatments that we were needing to finish, and we were dialyzing patients into the night. And so we had to make some accommodations in order to keep our staff safe while simultaneously taking care of our patients. We have a new assistant nursing manager for dialysis service, Kirk, and he started in November of 2020. And we're very happy to have him. He's making things move much smoother in our department. Next slide. Okay, next steps. We'd like to explore expanding our dialysis to the critical care pavilion. There's quite a long distance between 3 South and the ICU. And there's a little bit of a difference in grade. And so the machines are heavy and hard to push up that ramp. We'd like to try to find a space in which our dialysis machine can live so that we don't have that transport issue. We'd like to get a Press Ganey survey for patient experience. Our Press Ganey survey is for the different units in which the patients are admitted to, but doesn't specify whether they're dialysis patients or not. It's not separated. would like to standardize our patient education material so that it's so that the nurses don't have to decide or, inadvertently repeat the same topic over and over again. We'll continue to work with social services. Our patients have a lot of social health needs, including outpatient, well, including housing, social needs, mental health needs, transportation needs, and our case manager does a great job helping us with new outpatient dialysis placement. That's all I have for you. Thank you very much for listening. I'm open to any questions if you have.
Thank you very much, Dr. Ahn. Any questions from the board members? Oh, it's a critically important service to a highly challenging patient population. So we really appreciate the great work the dialysis team has been doing to make it available to our patients and maximize the quality. So thank you again, Dr. Ahn.
Thank you.
Okay, we'll now move on to our finance report with Chris Henry.
Okay, thank you. So tonight we'll be going over Washington Hospital's operational and financial results for December 2020. And we'll jump right into our acute inpatient statistics. Really, the story here is very similar to what we've seen all year with lower admissions. Admissions were lower by 62 in the month, but patient days were higher than budget by nearly 25%. The patients that are showing up are much more acute than what we've seen in the past. You'll see that in just a moment when we look at the case mix index. But really, those longer lengths of stay showing in the average length of stay and our average daily census. So again, fewer admissions, but patients staying a lot longer when they do get admitted to the hospital. As I mentioned, our case mix index for the month at 1.644, it really did spike up in December as we saw the census in the house spiking up in December as well. Deliveries for the month were as low as I think we've seen them in a long time, 109 deliveries for the month, 43 below budget. Surgical cases, 32 below the budget. We'll see the details of that in a moment. Likewise, cath lab procedures below budget by 35. Outpatient visits for the month above budget by 260. Our emergency room visits, excluding RSTU visits, pretty close to budget. And our RSTU visits, 682 below budget. We did close the RSTU mid-month in December and started directing preoperative patients coming for COVID testing to our new pre-op COVID testing area in the old ED, and patients that were showing up with symptoms would go through the emergency room. And again, we started that mid-month. Went too far. Looking at the utilization statistics in the OR and cath lab, surgical cases, like I said, were 32 below budget. 22 of those came from joint replacement cases. I do want to note that 9 of those occurred in the week between Christmas and New Year's when we started canceling or delaying elective procedures. The census in the house towards the end of December had really spiked up. We needed to make sure that we had enough beds for the patients that needed to be admitted. So we did stop doing a lot of the elective work. And again, 9 of those 22 occurred in the last week of the month. Neurosurgical cases were pretty close to budget, just 1 below a budget. Cardiac cases right on budget for the month, and general surgery 9 below budget at 162. In the cath lab, 35 cases below budget overall. 60 of those occurred in peripheral vascular area. Cardiac procedures 20 below. Those were offset by non-vascular interventional radiology procedures that were 44 above the budget, and our neuro-IR procedures were 1 above budget. Looking at productivity, productive FTEs for the month were 132 above budget at 1,331.8, and a lot of this being driven by census. Non-productive FTEs for the month were 31 below budget at 211.5, and I think everybody was busy working. You didn't have time to take time off. So our total FTEs for the month were almost 101 over budget at 1,543.3. Our FTEs per adjusted occupied bed, which is our productivity measure, 0.52 below budget at 6.17. So, you know, again, we had a lot of people in the house and the staff was working very hard. Moving into the financials. And as always, we'll look at our Governmental Accounting Standards Board presentation first, which, for those not familiar with it, is the presentation we're required to use for our audited financial statements. Total patient revenue for the month came in 10% above budget, $16,904,000 at $183,360,000. However, our deductions from that revenue for insurance agreements and such came in higher than budget at 78.46. We'd expected 77.45%. We'll take a quick run through that. Our contractual allowances, which result from our agreements with both the government and privately insured patients, came in 11.8% higher than budget. Again, our payer mix continued to be weaker than what we've seen in the past. Governmental sponsored patients made up 73.2% of that, of gross patient revenue versus 70.7% expected in the budget. PPO, on the other hand, was 22.1% of gross patient revenue versus the expected 24.6%. So again, that really pressured our contractual allowances to be higher than expected. Our provision for bad debt and charity, however, came in pretty close to budget. Although when you look at the percentage of change in gross revenue, you'd expect that to be a little bit lower, but a little bit higher. However, private pay in the gross revenue made up 1.7% of gross revenue versus 2.07 in the budget, so we got a little break there. So again, our total deductions came in almost $15 million higher than expected at $143,870,000. Moving into our expenses. So we end up the month after all those write-offs with net operating revenue almost $2.2 million higher than budget at $40,055,000. Operating expenses were almost $2.5 million higher than budget for the month. Number of areas driving that, of course, with our higher FTEs, our salaries and wages were almost $1.5 million higher than budget. Our benefits, while they looked pretty close to budget, there are a couple offsets going in there. Our Blue Shield claims for the month were almost $730,000 higher than budget for the month. We continue to see higher claims. We've seen them the last couple of months. So hopefully that trend will start to tail off. That was offset by some savings in our pension expenses that has resulted from really the strong performance of our pension investments, offsetting some of that cost. Supplies for the month were $813,000 higher than budget. Of course, a lot of that driven by volume. We did have a large purchase. Our drug costs drove about $702,000 of that. We did have a very large purchase of remdesivir in the month that drove that up about $562,000. And then our PPE costs were $235,000 higher than budget. And again, with the large number of people in-house during the month, we were burning through that PPE. Also, in our utilities, insurance, and other category, that was a higher than budget by about $284,000. We did have some shared savings on a Medicare bonus that we get through our ortho program that we had to pay out, and also some ventilator rental drove that number up. So we ended up the month with an operating bottom line showing a loss of almost $2.3 million against a budgeted loss of just under $2 million. Non-operating income for the month came in with a non-operating loss of $745,000, largely driven by some that you see there in about the middle of that category, bond issuance costs. You know, we had delayed our bond issue. This was the refinance of our 2010 revenue bonds. We had delayed it earlier in the year, and we really were not sure when we were going to go out to the market given the unstable conditions. We ended up going out right around this time in the month and incurred some of those costs in December. But, you know, it was well worth it. That refinancing saved the healthcare district $11.3 million over the life of the bonds, and we should see an average of about $1.2 million in annual savings on expenses. So we did spend $719,000, but it was well worth it. So we end up December with a total bottom line showing about a little bit more than $3 million loss against a budgeted loss of just under $2 million. Let me get this thing to move. Whoops, it delayed and went twice. There we go. Well, it doesn't want to go to that FASB slide. There we go. So now we'll take a quick run through our Financial Accounting Standards Board presentation. And this contains adjustments that the financial markets might make when they look at us. First thing we do is we reclass about $725,000 of interest expense related to our revenue bonds out of non-operating income and back up into operating expenses to end up with operating loss of a little over $3 million for the month from a FASB perspective, about $308,000 off of what we had expected. And then we move down into that non-operating area and we eliminate the interest expense related to our general obligation bonds and the related tax revenue that supports that interest expense. And we also remove our very small unrealized gain, about $14,000 on investments in the month, to come up with a non-operating loss of about $310,000 for the month, and a total bottom line from a FASB perspective of $3,353,000. And I don't know what happened there, Sri. There we go. Now we'll take a look at our earnings before interest, interest, taxes, depreciation, and amortization. We look at this presentation to get an idea of the actual cash income that we are generating. First thing we do is we pull depreciation out of our operating expenses, as that's a non-cash line, really represents cash flow that's already occurred. And we look at our bottom line without depreciation to come up with EBITDA for the month of $1,728,000. Then we move down to our non-operating line and we pull out that interest expense. And non-operating without that interest expense generated about $1.151 million in income. So combined, our operating and non-operating activities generated about $2.9 million in income to support that bond interest and some of the other capital spending and other initiatives here in the hospital. So are there any questions on December's results?
Chris, it looks like one of our big financial challenges has been the change to a less favorable payer mix. How much of this do you think is due to the COVID patients versus the change in the non-COVID patients? And what do you see looking forward as far as having a more favorable payer mix later
Yeah.
this year? And
Yeah, my sense of it is that, the COVID patients tend to be, the long length of stay in particular, tend to be Medicare patients. And, as you know, Dr. Nicholson, we have a fixed payment for Medicare. And when they stay longer, they generate more income. They may generate more charges, but not more income. I think that's part of it. And also, I think folks are still just hesitant to come to the hospital for a lot of the elective procedures that we perform that really are part of the income generator of the hospital. So, that's really my sense. Kimberly,
Yeah, I think that's,
thoughts on that?
yeah, I think those are the two factors. I think there's also, I think people, unfortunately, there are some unemployed people that have looked at other ways of trying to gain insurance. And so, we see that other government-sponsored plans. So I do think that it's just with those long lengths of stay and the predominant type of patients have been our Medicare patients with COVID, and so as hopefully our numbers level off, that we will be able to see greater other volume coming through. You'll see in January that a lot of our outpatient volume decreased again because our COVID numbers, January is probably the highest number. We saw the highest number of COVID patients we've seen yet in the pandemic. So, you saw our surgical volume going down so that we could be able to take care of any patient coming through our emergency room that needed care. And patients weren't coming in for the outpatient services too. So we've really seen a change in the types of patients over the last number of months that we've been seeing here. But it's reflective of what the community, it's the needs of the community in terms of COVID patients.
We're also seeing a lot of that increase in government patient is coming in front with Medi-Cal. And I think and you'll see that particularly pronounced when Kimberly gives her presentation. Mm-hmm. There's a couple reasons for that, and I think one of them is, we're 9 months into this, and a lot of people are losing benefits. A lot of organizations have tried to keep their benefits going, but I think what we're starting to see is people are losing their benefits and they're starting to qualify for Medi-Cal. There's another impact that Kimberly will talk about that's more local, but when we get into this period, also as Kimberly mentioned, we started canceling or delaying elective surgeries in December, and that carried through well into January. And again, those elective procedures are part of our economic engine, and when we start canceling those, that plays around with our payer mix, because a lot of those come from PPO patients. So there's a number of things really pressuring that payer mix in the wrong direction for us.
Yeah.
Thank you, Chris. We clearly have our challenges ahead of us. Any questions from the other board members?
Yeah, I was wondering, is there any hope for more money coming from the federal government or the state government, any government, anywhere?
So let me just, so what's happening right now is we've heard that, as you know, President Biden is proposed a $1.9 trillion relief package, basically. And at this point, there is no additional funds, provider funds for hospitals in that. So, but our hospital association, American Hospital Association, the California Hospital Association, and the hospitals are all been getting together, writing letters to our representatives. I've reached out to both Representative Ro Khanna and Eric Swalwell, and talked about the need in terms of where things stand, because the funds that have been given out to hospitals have really only covered through June 30th, 2020. And we really need them, because for us in California, as we all know, really the biggest surge is hit between July 1 and the end of December, and really now through the end of January is what we're seeing. So the only funds that have been available at this point to date has been up through June 30th, and we're very thankful we got those funds. But we are now doing a big push so that the federal government realizes that there's this need for this other period of time.
Yeah. There is still some money left over from the original CARES Act. I think it's about 27 billion, and they tacked on 3 billion, I believe it was, in the HEROES Act that I think they intend to distribute, but to whom and when, we really still haven't heard.
Yeah.
Well, do you get any response from Swalwell or Ro Khanna at all? Do they interact with you about this, about our need?
Yeah, so as I said, we just, we wrote them information about it. I think there's also, they're busy right now. I know Eric Swalwell is involved in the impeachment trial that is happening at this point. So we are in the process of trying to get some time with both of them so that we can do a direct conversation with them. Because I did do that, if you remember before. I did meet with both of them individually. So we hope to get that on the books again. The big push just happened, so we hope in the next week to get involved with them again, and do another one-on-one so that we can tell them, really plead our case at this point.
Great, thank you, Kimberly. Any other questions? If not, let's take a deep breath and dive into January.
All right, to set the stage for January, I do want to just say, as I mentioned, we saw the highest number of COVID-19 discharges at 198 since the start of the pandemic. In December, we had 141 discharges, and prior to that, the monthly average from March to November was 35 COVID-positive discharges. And it ranged from, the low of 10 in March to the previous high that we saw was in August at 86. So looking at our preliminary gross revenue, we had 185.1 million for January, which was above the budget by 15.8 million or 9.3%, but below January of 2020 by 5.4 million or 2.8%. Inpatient gross revenue of 130.9 million was above budget by 23.4 million, 21.8%, and 4.3 million or 3.4% above January of 2020. Our outpatient gross revenue of 54.2 million was below budget by 7.6 million, 12.3%, and 9.6 million or 15.1% below January of 2020. And that just basically, shows where we've had to reduce some of our outpatient elective business during that time, and inpatient elective business. And so the increase in the COVID-19 cases basically drove the increase in the inpatient activity, as well as I said, the decline in the outpatient activity. Moving on to the key census. Our average length of stay of 7.49 was above the budget of 4.83 by 2.66 or 55.1%, resulting from the higher acuity of admitted patients. The average length of stay was also longer than the January 2020 average length of stay of 4.68 by 2.81 or 60%. So really, when we looked at this, the COVID-19 patients have a significantly higher than average acuity and length of stay. Of the 198 discharges in a month, 19 of them stayed between 16 and 39 days. And then I also just want to say we did look even further. 4 of the discharges that we had during that time had length of stay higher than 80 days, and one was even 276. So when we discharge that patient, that's when those days count in the length of stay. So just so that everybody's aware of that. So we had a number of cases that drove up the length of stay. It's sort of the combination of some outliers, but also then just a higher length of stay from the COVID positive patients. Our outpatient observation days were 6 or 3.5% above budget at 179. And our average daily census of 181.3 was above the budget of 142.9 by 38.4 or 26.9%. Looking at our admissions trend, admissions were below budget by 129 or 14.1%. Admissions for the month were 241 or 23.4% below January 2020, due in part to the shift in joint surgeries from inpatient to outpatient. And there were about 92 fewer inpatient joint cases compared to the prior year, again, due to the curtailment of our elective cases. Moving on to patient days, while admissions were below budget by 14.1%, this is our patient days of 5,620, we're above budget by 1,190 or 26.9%. This was the result of the longer average length of stay we experienced during this month. Patient days for the month were 700 or 14.2% above January of 2020. Now moving on to our surgical trend, total surgical cases in January of 286 were below budget by 78, 21.4%. Inpatient surgeries were 51 or 29.5% below budget at 122, and outpatient surgeries were 27 or 14% below budget at 164. Looking more specifically at our surgical activity, you can see our joint replacement surgeries were below budget by 37 or 24%, and joint replacement surgeries were 77 or 39.7% below January's of 2020. Our general surgical procedures were below budget by 34 or 19%, and also below budget of January of 2020 by 30.6%. Our cardiac surgery, surgical procedures were below budget by 5 or 45.5%, and our neurosurgical procedures were below budget by 2 or 10%. Looking at our cath lab trend, cath lab procedures for January of 330 were 16 or 4.6% below budget, and 1 or 0.3% below January of 2020. Inpatient cath procedures were above budget by 14 or 7% at 214, and our outpatient cath procedures were below budget by 30 or 20.5% at 116. Then looking at the breakdown of our cath lab activity, our cardiac procedures were below budget by 32 or 27.6%, and 25 or 22.9% below January's of 2020. Peripheral vascular cases were above budget by 1 at 0.6% and 23, 16.8% above the same period as last year. Non-vascular interventional radiology procedures were above budget by 1 or 1.4%, but 13 or 15.5% below January of 2020. Our neurointerventional radiology procedures that had a busy month, we were above budget by 14 and 14 above also January of 2020. Moving on to our deliveries continue to be down for this month compared to budget. We were at 91, which was below budget by 52 or 36.4%, and they were down 42 or 31.6% below January's of 2022. Our non-ER outpatient trend, again, outpatient visits for the month were down overall. You can see the visits were 6,571, which were below budget by 754 or 10.3%. These visits were below January of 2020 by 1,556 or 19.1%. And again, I think given the high number of COVID positive patients and the surge that all this area was experiencing, I think that it would have had a direct impact on our outpatient visits. Our lab visits were below budget by 51 or 1.8%. Our x-ray visits were below budget by 393 or 22.3%. And our cardiac rehab visits were below budget by 252 and 42.4%. And really with cardiac rehab, we have actually we are not able to do the group rehab as we've done in the past. So we're seeing really patients one at a time versus doing it in larger group settings. So that's also contributing to the volume being down compared to budget. Moving on to emergency room visits. Our emergency room visits of 3,712 were below budget by 477, or 11.4%, and were below the same period last year by 1,293, or 25.8%. And as Chris mentioned, we did close the RSTU unit on December 14th and opened the pre-procedure testing unit on December 16th. All right, so just going through the gross revenue recap, surgical cases were below budget by 78, 21.4%, driving surgical revenue down by 6.9%, or 1%. Our cath lab procedures were below budget by 16, or 4.6%, and had an unfavorable procedure mix, driving cath lab procedure revenue down by $1.9 million, or 15.2%. Emergency visits were below budget by 477, 11.4%, and had an unfavorable service mix, driving emergency room revenue down by $1.7 million, or 14.8%. Deliveries were below budget by 52, or 36.4%, driving birthing center revenue down by $1.3 million, or 37.2%. Our patient days were above budget by 26.9%, and patient acuity was high, driving room and board revenue up by $11 million, approximately 33.6%. The higher level of inpatient activity drove ancillary services revenue above budget by $16.5 million, or 21.7%. All right, moving on to our preliminary payer mix, and really in terms of seeing what we just were discussing in terms of December, you can see that the January was unfavorable. Our government-sponsored patient revenue made up 77% of total gross revenue. This is higher than budget by 5.8% and higher than the prior year of 3.4%. You can also see that our total Medi-Cal-sponsored payer mix is 5% above what we budgeted and also above January of 2020. Our HMO was 2.5% of gross revenue, which is below budget of 2.6%. Our PPO was 19.8% of gross revenue, which is below the budget of 24.2%. And our private pay was 0.7% of gross revenue, which is below the budget of 2%. So it's another challenging month in terms of payer mix. Looking at our productivity indicators, productive FTEs were above budget by 130.9, or 10.5%, at 1,381.2. Our non-productive FTEs were below budget by 1.1%, and 180.6. Our total FTEs were 1,561.8, which were above the budget by 128.9, or 9%. And the biggest driver of the variance was volume of 107.1. You can see that our productive FTEs per adjusted occupied bed of 5.39 were lower than the budget of 5.56 at 3.1%, which I think is probably one of the best we've seen in a while. And then also total FTEs per adjusted occupied bed of 6.09 were lower than the budget of 6.37, or 4.4%. Looking at our other outpatient statistics, you can see our Whitmith clinic visits were below budget in January by 553, 3.3% at 16,364. They do continue to do telehealth visits, and so that's helped to continue to drive some of the patients in order to be able to get appointments with the physicians that they need. Looking at the DevCo visits of 2,419 were below budget by 1,220, or 33.5% for the month of January. You can see that Washington Urgent Care was down 977. Basically, when the pandemic started, we reduced, we've been open from 8 a.m. to 8 p.m. We reduced that to 9 a.m. to 5 p.m. But then given the really we're not seeing the volume. People are not accessing urgent care. They're either trying to see their physician via telehealth or really not seeking out urgent care at this point. And so we continue to reduce the hours in December to basically 4 to 5 hours per day, given that the volume has not been there. Washington Outpatient Surgery Center was also down 109 visits. Our Radiation Oncology Center was down 46 visits, and this was basically due to the transition that we transitioned back from the Hayward facility to Fremont as we opened the center with a new linear accelerator. And when we did that, we had to slow down some of where the patients were going to get treated, and so now volume in February is basically back up to normal levels. And then Ohlone College Student Health Center has been closed during this time, and we are actually working to with urgent care to set up a telemedicine program in terms of any of these students that are going to need care. So that is also in the works. Moving on to key financial statistics and looking at days cash on hand for January ended at 155 days, a decrease of 8 days from last month. In terms of the two driving factors, revenue bonds debt service, we had to pay on 5 outstanding revenue bonds totaling $3.7 million, and we also had higher average operating expenses for the month. In February, we do expect to receive $8.7 million, which is about 7 days worth, in federal supplemental payments or from the hospital quality assurance fee. We did do an intergovernmental transfer of $2.7 million in December. So from that, we will get, as I mentioned, $8.7 million back. Also, we're expecting reimbursement. We did assist with the startup costs for the Peninsula Surgery Center, and we will be getting reimbursement for that in February. So in terms of looking at some help in terms of increasing our days cash on hand. Our days of gross revenue and accounts receivable were 65, really given the higher volume of high dollar, high acuity patients compared to last year. And we did see our charity care go up a little bit to 651,210. We have an applications pending or approved in January. And then lastly, this is for the quarterly report on the homeless patient activity. Looking at the 6-month period ending in December 2020, there were 1,176 patient encounters representing 520 homeless patients, of which 177 had more than one encounter during the period. The estimated total unreimbursed cost through December 2020 was about $2.8 million. And that is the end of the January preliminary operations report.
Thank you, Kimberly. Obviously, a challenging month clinically with a high COVID census and a challenging month financially with the payer mix and other challenges. Any questions from our other board members? Okay, it's now time to move to the action item section of the agenda, and this involves medical staff re-credentialing for both myself and my wife. And to avoid conflict, I'm going to be abstaining from any action which involves credentialing for myself or my wife, and I'm going to turn the gavel, a virtual gavel, over to Director Yee to conduct this section of the agenda.
Thank you. So regarding the credentialing action items pertaining to William Nicholson, MD, and Lucia Jimena, MD, do I have a motion? Oh.
Mike, you're muted.
You gotta, Mike Wallace, you need to unmute. Sorry, you're gonna have to repeat yourself.
Okay, you got me?
There
Yes.
you are.
Okay. In accordance with the district law, policies, and procedures, I move that the Board of Directors approve the medical staff credentialing action items as approved by the Medical Executive Committee on January 18th, 2021, with the exception of those credentialing action items
Oh, sorry.
pertaining to William Nicholson, MD, and Lucia Yamena, MD.
Sorry. Is there a second?
Bernie, you have to unmute yourself too.
Understand that. Are we doing this in two actions now?
Yes,
Yes.
yeah,
Yeah.
I did that wrong. So,
I'm with you then. I'm sorry. I second that.
okay, great. All right, we have a second. So Dee, can you take the vote on that, the first medical staff credentialing action item?
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Epen, Director Wallace.
Aye.
Thank you. That passes. So then we need to do what I already did, but
That's all right.
the credentialing item for Dr. Nicholson and Dr. Yamena. Separate motion for that.
Yes, Madam President. In accordance with the district law, well, I guess sitting president, sorry. In accordance with district law policies and procedures, I move that the Board of Directors approve the credentialing action items pertaining to William Nicholson, MD, and Lucia Yamena, MD.
Thank you. Thank you for the second. All right, do you take the vote for that?
Director Nicholson,
I abstain.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Epen, Director Wallace.
Aye.
Very good. That motion passes and I happily give the meeting back to Dr. Nicholson. Thank you.
Okay. I thank the board for granting the privileges to myself and my wife. We'll keep working.
Thank you.
So at this point, we've completed our action items, and I think we just have announcements remaining. Kimberly?
Yes, I do have a few announcements. I do want to start with Employee of the Month for February. This is Ravinder Sandhu she's a lead clinical lab scientist in microbiology. In 1996, Ravinder Sandhu was a student completing her clinical labs at Washington Hospital. She was so impressed with the culture and the mission of the hospital that after graduation, she began working here, at first as per diem and later as a full-time employee. The role of Raj and her co-workers intensified once COVID-19 became a part of our lives. Raj and the microbiology team built and validated every COVID test result. In a typical year, the laboratory validates one or two methods. It is an extremely labor-intensive process. This year, which was anything but typical, at least 5 different methods were used to complete more than 20,000 tests. Raj's leadership skills were critical to the success of this endeavor. Her passion for her work is obvious. Raj believes she and her coworkers are an important part of patient care. Every day, she finds her job very rewarding. When the vaccine became available, Raj gratefully was vaccinated along with her elderly patients. She believes as individuals, we should all do our part to move forward as a community to end this pandemic. Congratulations to Raj, our February Employee of the Month. So, all right, the next announcement that I want to do is talk a little bit about our COVID-19 community vaccination clinic. And I just there's a few slides in terms of showing you these. And so I want to why don't we go ahead, Sri, to the next slide. I think everybody is aware that we opened our community vaccination clinic on February 1st of 2021, and it's really being operated by our foundation, Washington Township Medical Foundation. It is located in Washington West in Anderson Auditoriums, and I'm sure if you've driven by the hospital, you see a number of our signs that are out. For the first week, that week of February 1st, that Monday through Friday, we did a total of 2,352 community vaccinations. At this point, we've scheduled 12,263 appointments through the end of March. We have additional capacity to do over 13,000 by the end of February, but we have also in the process of having to schedule some people with second doses. I think really that, it's very important. You could have seen that we basically saw received more than 37,000 phone calls. So I know it's been a big challenge in this community, and especially in Southern Alameda County, in terms of being able to get access to vaccine. And so as the community hospital for this community, we felt, and we've talked about it with the board, and I know the board really has said that how much it's important that we are able to vaccinate our community. So it's taken a great deal of collaboration between a lot of the different departments throughout the healthcare system, that we've been able to quite quickly stand up this vaccination clinic, and overall it has been very successful. Can you go to the next slide, Sheree? As you can see, really, there are a couple things. Who we can vaccinate is really very much dictated by the county, and so the county has allowed us to vaccinate all district residents who are 65 and over, and also all hospital patients that are 65 and older. And as you know, we've also been doing our employees and physicians of Washington, and as you heard for Dr. Killaroo, our number of physicians that have been vaccinated is over 90%, and we're around 80% and getting towards and pushing for more towards 85% for our employees, and even more. So, overall, that's been very successful. And also, we've been doing eligible healthcare professionals in other types of fields too. But we have to receive our vaccine from the county. So one of the biggest constraints is really knowing how much vaccine that we will receive and on a regular basis. So I think we have the ability to probably increase that. We do have the ability to increase that capacity, but it's really going to depend on our ability to get the vaccine through the county. So that's really been our biggest constraint. I think it's important. Does this work? Which I was going to try to do it. So I think it's important that everybody, the board, realizes how well this has gone, for our community. So I know we've done some social media posts, but I want to just kind of go through and show you some of the feedback that we've gotten from the community. So go ahead. I don't know who I'm.
Yeah, it's.
Okay.
Are we there? Next slide.
The previous.
Okay.
There you go. Sorry.
All right. So we've gone. Well, let's see. We've gone. All right. So as you can see, that we've had a number of posts from very much everybody. Very much appreciates it. I will read this one. I never thought today would ever come. Held back the tears of joy as mom received her first dose of the COVID vaccination. It felt like Christmas for both of us. Kudos to Washington Hospital for having such a great system and a great staff doing the vaccinations. Today we had our first dose, no pain, only great care and service by the entire staff of Washington Hospital in Fremont, California. Thank you. And I know we quickly went over a couple of the other ones, but those also are the same type of really the thanks, and I know all of us in the executive team have been over there and have talked to the patients coming through, and people are just so excited to be able to receive their vaccination, and you see tears in their eyes, and they're just so thankful that they're able to receive locally their shots. Go ahead and you can go through a few more. Again, returned home. Very, very impressed in how well run and organized the event was. A big thank you. Thank you so much for everything. It went smoothly, knowledgeable, and made the whole process great for us. thank you again, and please share this with everybody. Go on to the next one. These are just a few. Thank you for an excellent communication on COVID vaccine availability. It's much appreciated. Again, a lot with my mother, received her first COVID vaccine. Just wanted to say a big thank you for an extremely efficient process that it was. So these, again, are just some of the compliments that we've been receiving. You can keep going. I want to express my gratitude to our community hospital for COVID-19 vaccine program. I was a bit nervous after hearing my friend's experience in another county and in another hospital in our area. They reported long waits at the spot, cancellations, lack of clarity of registration, but the experience was very different at Washington Hospital. So you can see in terms of, we've also, in the Tri-City Voice, we talked about sort of what was happening that's been out there on the February 9th issue. Go ahead. And really just showing some pictures of so many happy residents and patients for being vaccinated. So I want to thank the board of directors and everybody for really allowing us to be able to do this for our community. I think go one more slide. We're having technical, there we go. And you can see this is a lot of our workers of everyone working at the vaccination clinic. It really does take a number of people to make sure that this is run effectively and efficiently. And as I said, we also have a call center that is taking all these thousands and thousands of calls that we've been getting. I think there's one more. And again, in terms of proud to be a locally owned district hospital vaccinating residents 65 years and older, regardless of where they receive their medical care. And that's really important. We are the hospital here for our community in time of need, and it really shows that the importance of us being able to do this. So I felt it was important that shared that with the board this evening.
Well, Kimberly, on behalf of the board, I'd like to thank you and the executive team and the whole House that has engaged in this monumental effort to make vaccines available to our community, because this is going to be our salvation from this pandemic, which has hurt us so badly. So thank you so much. And we just hope that Alameda County Public Health Department hears this and knows how well it's going in our community, and that they'll continue to send us vaccines so that we can have this as an ongoing effort.
And I do just want to say it's the community support that has also helped us to allow us to do this. I am thrilled to be able to say that from our charitable foundation and that we have surpassed our goal for the COVID-19 Emergency Relief Fund, raising more than $1.17 million in support of vaccine distribution, testing, and other immediate COVID-related priorities at Washington Hospital. And we just received a generous gift recently from Fremont Bank Foundation that helped us to put that over, and specifically going towards our vaccine distribution and vaccine clinics. So it's very important. And we've also received a lot of support in terms of our community from weekly meal deliveries. And so I do just want to thank the community for their support too. So those are my announcements this evening.
Great, thank you very much, Kimberly. Any questions or comments from the board members? I see a lot of smiles there that this is moving forward, and hopefully we'll see this is the shining light at the end of this very, very long tunnel. So hopefully we'll get through this very well. Kimberly, do we have need for a closed session tonight?
We do not.
Okay, very good. Are there any comments or questions that the board members want to make at this point?
Keep up the good work. Hang in there.
Yep. Well, thank you. And there being no further business before this board, this meeting is now adjourned. Thank you. and good night.
Yeah,
Thank you.
And stay safe.
everybody.
Thanks.